7, and as you know, it is my aim to get through all of surgery in 2 hours. So let's get started. Thank you, magical light person. So the disclaimer is I made this PowerPoint. It doesn't have any divine intervention from anybody who writes test questions. Dr. Estrel took a look at it, but it's not officially sanctioned by the school. This is basically something I made for myself to study for Step 2 this summer, kind of going back over all my surgery notes and the books and test questions or Q-Bank questions that I used to study for both my surgery shelf and for Step 2. So, will all of this absolutely be on your shelf? No. But I tried to cover what I remember being important and what the review books and the Q-Bank questions seem to hit over and over again. So you'll also notice that I'm not going to teach you a lot of surgery in the next 2 hours because there's not a lot of surgery on your shelf. So I tried to pick out the medicine concepts that are related to surgical patients, which is really the most common thing you're going to see in these clinical vignettes. So I tried to make this PowerPoint fairly interactive. It's not like hardcore pimping, but it was my goal to make this a way to kind of see what you know and see what you still need to study before Friday. So there are questions. Please participate if you would like to. Harlingen, you guys have little buttons and stuff you can push, so please participate also if you know the answer. And keep me honest. If they're saying stuff and I'm not repeating it, let me know if you're getting lost or if I'm not remembering to repeat things like I should. So, any questions before we get started? Yes, ma'am. Yes, so it is being audio and videoly recorded right now. So the actual presentation is going to be posted. Dr. Hinsey's going to send it out first thing tomorrow morning. And the slides also will be sent to you guys tomorrow if you want to review it. So I'm going to go kind of fast. So unless you are a compulsive note taker, it might just be easier to listen and enjoy. So all of this material will be available for you guys tomorrow. All right. So we'll begin, like most of our patients begin before surgery, in the preoperative evaluation. So, surgeons love to operate. There are very few absolute contraindications to surgery, but there's one that seems to come up over and over in the Q-Bank questions for surgery. Anybody know it? When can you absolutely not do surgery? Any ideas? Besides patient death. That one doesn't count. So diabetic coma. DKA is an absolute contraindication to surgery, or sky-high glucose, just because the risk of operative complications and infection is just too high. So that's one of your number one absolute contraindications to surgery. Poor nutritional status is another thing that's going to make the surgeons wary to take someone to the OR. And there are 3 things we look at that are measures of nutritional status. Anybody? When would we think someone's nutrition sucks? Albumin. So if the albumin's low, what else? We can weigh them. That's easy. If they've lost more than 20% of their body weight, that's also a marker of poor nutritional status. And the other one, the plastic surgeons check it a lot. Prealbumin, I agree. That's not the one I put in here. It was transferrin. So albumin less than 3, a transferrin less than 200, or overall weight loss greater than 20% of the body weight are all pretty strong indicators of poor nutrition. So if the surgery is not emergent, these are good reasons to delay surgery and maximize nutrition. So if we're trying to maximize someone's nutrition, what's the best way to do that? Should we shove them full of TPN or what? Is that the best way? No. What's the best way? Yes, enteral feedings are always preferred. If it's possible to feed somebody through their gut, that's always going to be a more optimal way to get nutrition into somebody. So severe liver failure is also a reason that surgeons will delay surgery if possible or not take a patient to the OR right away. And there's some things we can check to measure liver function. What are those? Bilirubin. So we look at bilirubin. If we're cutting somebody open, what are we particularly interested in? Coags, yeah. So we for sure want to take a look at the PT. So bilirubin, PT, we're also interested in the ammonia level or signs and symptoms of encephalopathy. Those are some things that are really important to look at in the preoperative evaluation. So, good. And if they're a smoker, what is our best advice? Okay, quit. Yes, good. And if possible, 2 months before surgery, just because smoking affects wound healing, because of the way it negatively affects the remodeling of tissue. So we'd really like our smoker friends to stop smoking 2 months before surgery, particularly in plastic surgery cases. I know my attending was a real big stickler. If he was going to do a flap reconstruction on somebody, he was not going to do it if they were still smoking. So that's important. And also with our smoker patients, what is important as they're coming out of anesthesia? We've always got a pulse ox monitor on our patients as they're coming to, as the anesthesiologist is waking them up. Do we want to keep their SATs right at 100%? Why not? Absolutely. So smokers, people with COPD, they tend to be chronic CO2 retainers. So the only drive they have, or the strongest drive they have for respiration, is hypoxia. So if we keep their SATs too high, that's going to suppress their respiratory drive and actually might cause more problems in the waking up phase after surgery than would be worth. All right, so Goldman's index, you can actually calculate a number from Goldman's index to calculate preoperative or operative risk. So really what you need to know about it, not necessarily how to calculate it, but what it does. So it tells you about a patient's risk during surgery, and it allows you to kind of weigh the risks and benefits of taking somebody to the OR. So what you do need to know for your test, not necessarily calculating the score, but what's the most important factor? What's the, what? CHF. So congestive heart failure, the ejection fraction, these are all things we're paying very close attention to in the preoperative evaluation, because CHF gives us the biggest amount of points in Goldman's index, and it's the biggest predictor of perioperative mortality. So if we have a patient with known CHF, I think I spilled the beans on this one already. What are we checking? Ejection fraction. Yeah, so we're going to order an echo if the patient has known CHF, and if their ejection fraction's in the toilet, if it's less than 35%, no surgery for them if it's absolutely, unless it's absolutely necessary. So the second most important factor for predicting mortality associated with surgery. Yes, so angina-ish, but more importantly, a recent MI. So 6 months is the cutoff, and it's kind of a surrogate for their cardiovascular status. So angina would factor in there, but really we're going to be super concerned if there's been a heart attack within 6 months. So what are we checking on all our pre-op patients here? Everybody gets one of these if they're over 50. EKG before surgery. So if the EKG is abnormal, then we'd send them for a stress test. If the stress test is abnormal, we got to send them to the cath lab and do revascularization or reperfusion either with stenting or revascularization with a cabbage. So unless the surgery is urgent, we really want to make sure that they're cardiovascularly optimized before we take them to the OR, put them under anesthesia. So some other things we can check also that would show up on the EKG. Arrhythmias are a strong predictor of whether or not someone's going to do well with surgery. If they're old, they're less likely to do well with surgery. They're less likely to do well with surgery if the surgery is emergent. And aortic stenosis is also a predictor of complications associated with surgery. So what else should we check? Particularly with number 6. So we already got our EKG. PFTs, sure, but we're not especially concerned about that if someone's got a history of valvular disease. Well, first we're just going to listen. So, and this is the way they try to sneak some medicine in with your surgery questions. They might describe a patient who comes in for his preoperative evaluation, and they might describe the AS murmur. So you're going to have to reach back into your memory banks from step 1 land and remember what the murmur of aortic stenosis sounds like. And it is late systolic. It's a systolic ejection murmur, and it's got that characteristic crescendo decrescendo. So even though it seems very medicine-y, it could show up in a vignette concerning the preoperative evaluation. So before surgery, what medications do we tell our patients to stop? Aspirin. How long before surgery do we need to stop aspirin? Yeah, 7 to 10 days. 2 weeks, I think, is even better if they can. What else would we want them to stop? NSAIDs, sure. So, metformin. Why? Yeah, so remember that was the big adverse reaction you had to memorize for step 1 with metformin, lactic acidosis. So those are the main ones. Aspirin, NSAIDs, also vitamin E, because that can affect bleeding and clotting. Optimally 2 weeks before, but 7 to 10 days is usually what we tell our patients. Warfarin also because of bleeding complications, and we monitor the INR for that. We want it to drop below 1.5 if possible. And metformin, which I don't have here, but it's absolutely true due to its risk of lactic acidosis. And then if the patient is diabetic requiring insulin, we always instruct the patient to take half the morning dose since they are NPO after midnight before surgery. So if they are chronic kidney disease and they're on dialysis, when do they need to have dialysis before surgery? Yeah, 24 hours before, absolutely. And why do we check BUN and creatinine in a patient with a history of kidney disease? How does that affect surgery? Like, sure, their kidney function isn't that great, but the surgeon shouldn't care about that. Just cutting on them for an hour. Absolutely. So what he said was, if you guys didn't hear him, people with chronic kidney disease who have uremia, uremic toxins actually interfere with platelet function. So even though if you check a CBC, the platelet counts will be fine, there's still an increased risk of bleeding because the uremic toxins prevent them from interacting in a normal way. So particularly if the BUN is super high, above 100, we would definitely worry about that. So that's one of the reasons we want to make sure they get their dialysis before surgery, and we monitor their BUN and creatinine closely. So what would you expect on the coag panel? Kind of told you already. The platelets are normal. They'll try to throw you off with that one, but the bleeding time is still prolonged because bleeding time doesn't necessarily measure platelet number, but definitely platelet functionality. Okay, so if you are a whiz with the ventilator, you're a better med student than I. I kind of boiled it down to the 4 things you really need to know to answer questions about these surgical ICU patients. So assist control, what do we use this for? Or how much is the machine actually doing for patients when they're on assist control setting? Yeah, so we set on the machine, we set the tidal volume that we want the patient to receive and the rate, the minimum rate that's acceptable for us for the patient to be breathing. But if the patient, is exercising their respiratory muscles and takes a breath, the ventilator will go ahead and give that predetermined volume. That's different for pressure support, where the patient is going to breathe however often they're going to breathe, but the machine provides pressure support, so that if they're not able to take in the whole tidal volume on their own, the ventilator will give a little bit of oomph, a little bit of help with that. And as I noted on the slide, this is an important weaning setting. That's probably where you'll see it, if you see it in a clinical vignette. You've got someone that's been vent dependent after a bad accident or whatever, and you're trying to wean them off the ventilator so they can be downgraded. Pressure support setting is an important stepping stone in that process. And then CPAP, my daddy's got one of these. So again, the patient has to have sufficient respiratory drive to breathe on their own, but a CPAP gives continuous positive pressure in order to make sure those alveoli stay open in order for gas exchange to occur. And then PEEP. Yeah, so again, this is more important, keeping those alveoli open. As I've noted on the slide, where you'll see this is as the setting that's used in patients with ARDS. So the alveoli are collapsing, and that's what's causing the problems in patients with ARDS not being able to facilitate gas exchange. The PEEP setting is going to keep those open in order to facilitate that. So if you have a patient on a ventilator, what tests do you want to order with some regularity to check how well the ventilator is working? ABG, absolutely. So you're going to check your oxygenation status and then how well your CO2 is being taken care of as well. So if the PaO2 is low, what does that tell you? Is your patient getting enough oxygen? No. So how do we want to remedy that? Absolutely. So we'll increase the FiO2 if our PaO2 is unacceptably low on the ABG. If the PaO2 is too high, yeah, we'll decrease it. Why? What is there such a thing as too much oxygen? And what does too much oxygen do? Yeah, free radical damage. So it can actually paradoxically end up worsening ARDS or lung injury if you have too high concentrations of oxygen. So if we're taking a look at our PaCO2, if it's too low and our patient is alkalotic, what should we adjust on our ventilator settings? Ooh, I can't hear you. So we could. What would we want to do to frequency? We want to make them breathe faster or slower? We would want to make them breathe slower because if their PaCO2 is low, that means they're blowing it out, right? They're breathing too much. They're like hyperventilating. Is that the only way we could adjust this PaCO2? Tidal volume. So frequency and tidal volume are the two parameters you could change. And I think I might have taught you this way back in first year in physiology. Which one is better to adjust? Do we want to adjust rate or do we want to adjust tidal volume to get the most bang for our buck in terms of efficiently getting rid of CO2? Tidal volume. Why? Multiplicative effect, what do you mean?
Your minute ventilation is tidal volume times rate. So if you're increasing your rate, you're not increasing as much.
Well, so you didn't press your button, that's okay. So what he said is it was a multiplicative effect, and it's because you multiply rate and tidal volume together to get your minute ventilation.
Right, so if you multiply a factor of 100 versus a factor of 3 in your rate.
I agree with that. The only thing I would add in that you might want to look for in the answer choices is when you're increasing your respiratory rate, you're also increasing ventilation to the dead space. So when you increase rate, you're getting more air to your alveoli, sure, but you're also getting more air to the dead space in your trachea and your bronchi and stuff like that. Whereas when you increase your tidal volume, that gives more benefit to the amount of air that's going into the functional spaces where gas exchange can occur. So that's a pretty classic question and a good thing to remember, how physiology does apply to real life. So then conversely, if the PaCO2 is high and the patient's acidotic, we could increase either rate or tidal volume, but again, tidal volume is going to be preferred because we're not wasting any of that additional oxygen on dead space. So, okay, very good. So for acid-base disorders, you'll see these acid-base disorders on pretty much every shelf exam you take this year. So it's good to get it down early, and then you can get the questions right on the rest of the exams also. So remember, when you're worried about acid-base status, obviously the first step is going to be to check the pH. You can get that on your ABG, and if it's less than 7.4, you've got an acidotic situation. The next step is going to be to check the bicarb and the PCO2, because then you can see where the problem is. Do we have a problem with the kidneys or a metabolic issue, or do we have a problem with CO2 retention or blowing off of CO2? So if the bicarb and the PCO2 are both high, what type of acidosis do we have? Respiratory. Very good. So if our PCO2 is high, right, we're retaining our PCO2, and because of the carbonic anhydrase equilibrium equation, more PCO2 means more protons, and that gives us acidosis. So if bicarb and PCO2 are both low, then what type of acidosis do we have? The other one, metabolic, right. So if we have too little bicarb, then the problem is with metabolism. So once you have determined you've got a metabolic acidosis, the next best step on your test should be to see if they gave you electrolytes so that you can calculate the anion gap. So remember the equation for anion gap. You're likely going to need to use that on one of your questions on Friday. And it's just sodium minus the negatively charged components, chloride and bicarb. And what's normal? 8 to 12. 8 to 12, somewhere in there. There's a more sophisticated equation where you can calculate the normal anion gap based on the patient's age, but that's an internal medicine thing. We don't care about that now. So 8 to 12 is a good enough ballpark for normal. And what are some things that can cause an anion gap acidosis? Or just give me the cute acronym that was in first aid. Mud piles, right? So what are these? Let's see if I can remember. M is methanol, I think. Is U uremia? D, DKA. P? Yeah, okay, paraldehyde. I? Isoniazid. L? The most common one, lactic acidosis. E? Ethylene glycol. Or ethanol, sure. Then S, salicylates, good. Okay, so the non-gap acidoses are easier to remember for me, because there are fewer of them. What are they? The main one? Main one's diarrhea, right? Because your colonic and intestinal secretions are high in bicarb, so if you're pooping a whole bunch, you're going to poop out a lot of your bicarb. And low bicarb indirectly gives us a metabolic acidosis. So some other random ones that are more internal medicine things are the renal tubular acidoses and then abuse of diuretics or overuse of diuretics. So if our pH, instead of being low, is too high, is greater than 7.4, we've got an alkalosis on our hands. And again, the next best step is to check the bicarb and CO2. And if they're both low, what type of alkalosis do we have? Bicarb and CO2 are both low. What type of alkalosis is that? Respiratory, right. Because low bicarb, we just talked about that. That should give us an acidosis. So low bicarb isn't going to give us an alkalotic situation. It's got to be the CO2. And if they're both high, then conversely, that's a metabolic alkalosis. So to determine between the main classes of metabolic alkalosis, you can check the urine chloride. And vomiting, because you're puking up HCl, which is rich in chloride, you're going to have low chloride when you check it because you're ejecting it into the outside world. If the chloride is high, then it's something a little bit more mysterious. It might be some kind of hyperaldosterone state or one of these random genetic nephron electrolyte transporter problems like Barter's or Gittleman's. So that's kind of down and dirty, the stuff that you need to recall, pull out of the memory banks for the acid-based questions you might be asked. So as far as electrolytes, low sodium, what causes hyponatremia? Yes, too much water, fluid overload. So if you remember from second year, hyponatremia is not a sodium problem, right? It's not that you have too little sodium, it's that you have too much water. So the next best step, if you see on your chemistry that you've got a patient with hyponatremia, you want to check the plasma osmolarity because there are some mimickers of hyponatremia where you've either got high glucose and that makes it look like your sodium is too dilute. So you want to check the plasma osms to rule that out. And then the next step is to take a look at the patient and assess the volume status. So if your patient is hypervolemic, they're puffy, their lungs are crackly and wet, and they've got hyponatremia on chemistry, what might cause that? Yeah, so the big three, CHF, nephrotic syndrome, or cirrhosis, can all cause fluid retention and lead to hypervolemic hyponatremia. Well, that's the same thing twice, isn't it? So pretend that second arrow is pointed down, and you have got a patient with dry mucous membranes, skin tenting. They look like they're volume depleted, but they're still hyponatremic on chemistry. So what could cause that? Yeah, diuretics or vomiting, or this isn't the psychiatry shelf, but if someone's just, vomiting free water. Never mind. So diuretics or vomiting are going to be your main ones. And then if their volume status is stone cold normal, but they're hyponatremic, the big cause there is SIADH. So the next best step, once you've established that, especially if the patient is a smoker, would be what? Chest x-ray. SIADH is a paraneoplastic syndrome associated with lung cancer. So, okay, so how do we treat hyponatremia? Kind of depends, right? It depends on the volume status. In general, the garden variety answer is fluid restriction and diuretics. But if they're hypovolemic, what do we want to do? They're hypotensive, tachycardic, dry mucous membranes, skin is tinting. Got to volume resuscitate them, right? So even though they're hyponatremic, we're going to want to give them fluid to correct for hypovolemia. Something I always found confusing when I was taking practice questions and when I was taking the real test is what is the role of hypertonic saline? When do we use this as opposed to just fluid restrictions and diuretics? And there are some pretty clear-cut criteria. Does anyone know them? So if you've got severely symptomatic hyponatremia, so if you're like seizures, altered mental status, like severe symptoms, or if the sodium is super low. I've seen cutoffs either 110 or 120. I don't think the test is going to be dirty and say 115, but I mean you'll see it's very low, or the patient is symptomatic from their hyponatremia. So why don't we go willy-nilly with this hypertonic saline and correct all our sodium up to normal in like 5 minutes? Central pontine myelinolysis is the big fear from Lawsuit City, right? So we want to make sure we replete the sodium, or correct the volume problem rather, very slowly so we don't induce this life-threatening complication. And what's an appropriate rate of correction of the sodium? It's between 0.5 and 1 milliequivalent per hour, or between 12 and 24 milliequivalents a day. Any faster than that, and you're asking for central pontine myelinolysis. So for hypernatremia, again, the problem is not with sodium, it's with water. It's when we've lost too much water with respect to our sodium content. So the treatment for this is we want to replace the water. So we're going to replace fluid with a hypotonic solution. And if we go faster than 12 to 24 milliequivalents per day, what do we worry about? What's the complication? Cerebral edema. Good. So cerebral edema is the feared concentration here. Got a lot of fist bumps going on over there. Okay. So some other electrolyte abnormalities and how they might present in a clinical vignette. If you've got a patient with numbness, those two dead people sign, or prolonged QT interval, what electrolyte is out of whack? Calcium. Too high or too low? Too low. So that's hypocalcemia. And what about the classic bone stones, groans, psychiatric overtones? That's hypercalcemia. And what we worry about with hypercalcemia is this shortened QT interval. With hypocalcemia, as you can see on the slide, you've got a prolonged QT interval. So anytime you see that the calcium is either too low or too high, an EKG would be an appropriate next best step to make sure your patient isn't at risk for developing torsades. Okay, so what about a patient with paralysis, ileus, or ST depression and U waves on the EKG? Hypokalemia. And how do we treat hypokalemia? Yeah, we'll give them potassium. Good. So we'll put potassium into the IV fluids. We just want to make sure that we monitor their renal function. If their creatinine is too high, if they're in renal failure, we can bump them into hyperkalemia pretty quick. So, which brings us to this last situation, peak T waves and other EKG changes like a prolonged PR or QRS, that's hyperkalemia. And the treatment of this is super importante. So what do we want to do to a patient with hyperkalemia? Calcium gluconate first. This is going to stabilize the cardiac membranes. What else? So we can give insulin and glucose to shift the potassium into the cells. Albuterol or a beta agonist can also shift potassium intracellularly. And then if it's really bad, we really have to do dialysis to get the potassium out of the body. So very good. Okay, K-Exolate. We don't really use that very much at University Hospital, but they still use it at the VA from time to time. That makes you poop out potassium. So it's another way to kind of get it out of the body. Okay, so for fluid and nutrition, the maintenance IVF of choice, it's D5, half normal saline, and we can add 20 milliequivalents of KCl if the patient is peeing. And for maintenance fluids, how do we calculate it? Up to 10 kilograms. How much fluid do they get? This is also muy importante. What? Yeah, so there's different formulas, whether you're calculating daily requirement or hourly requirement. I've got the daily requirements here. So 100 milliliters per kg per day for the first 10, then 50 milliliters per kg per day in the next 10, and 20 milliliters per kg per day, all kilograms in excess of 20. So as we discussed before, enteral nutrition is always preferable over parenteral nutrition. And really, we only use TPN when we have to. When there's a problem with gut absorption, that would prevent us from getting the patient nutrition enterally. Okay, so our burn patients. For circumferential burns, well, first of all, what degree burn do we have going on here? It's erythematous. It's fairly painful, but not peeling. So that's first degree. And what layer of skin is involved? Epidermis. And so in this second example, we've got loss of integrity of the epidermis. It's very painful. Oh, there you go. JK, second degree burn. And then lastly, this example of a third degree burn shows you that it can either become dark or pale. And really, we have no sensation here because the damage to the skin goes all the way through the dermis and starts to affect the nerves. So even though this doesn't hurt, this red stuff all the way around the area of the third degree burn hurts like hell. So just because the patient has a third degree burn doesn't mean something doesn't hurt. Okay, so particularly, what are we worried about in circumferential burns? Compartment syndrome. Very good. So we'll look out for those signs, and if we see them, we'll definitely want to consider a bedside surgical procedure to relieve that pressure. If a patient comes in with kind of burned hairs in their nose, they're wheezing, they got black stuff all the way around their mouth, what's the complication we would fear there? So we're worried about their airway. They could develop laryngeal edema, so we're going to have a low threshold for intubation there. And then if a patient who was kind of in a house fire or something comes in with confusion, they've got a headache, and their skin is really, really red. Carbon monoxide, we'll want to check the carboxyhemoglobin. Remember that a pulse ox doesn't do you any good here. Why is that? Yeah, absolutely. So carbon monoxide actually causes a leftward shift of that hemoglobin-oxygen dissociation curve, and the hemoglobin molecules are more saturated. Good. So the treatment here, we want to give them 100% O2, and if we have a lot of carbon monoxide on board, we might consider hyperbaric treatment. Okay, so clotting. What is the cause of clotting that we worry about in old people, particularly me? I worry a lot about this. Not for me, but for my future patients. Giving you a hint and it's not being helpful. Cancer, yes. Cancer is a hypercoagulable state. So in old people that have a sudden, increase in clots, hypercoagulability, we're going to worry about cancer. What about a patient who's got some new clots and they're edematous, they got high blood pressure and foamy pee? What might be a cause of a hypercoagulable state that would cause edema, hypertension, and foamy pee? Not cirrhosis, but it's an osis. Nephrosis. So nephrotic syndrome is a hypercoagulable state because, remember, in nephrotic syndrome, we're losing protein in the urine. And some of the first proteins to go are things like antithrombin 3 and a lot of other clotting factors. So nephrotic syndrome in and of itself is a hypercoagulable state. So that's important to remember. This is kind of one of those instances where medicine sneaks into your surgery shelf. If a young person has a positive family history of clotting, the most common inherited coagulable hypercoagulability is factor V Leiden. And why do we care about antithrombin 3 deficiency as surgeons, or at least as surgery students? What can't we give to someone with AT3 deficiency? Heparin, because it won't work. Very good. So a young woman who has multiple spontaneous abortions, lupus anticoagulant, could be concerned about that. And in a patient post-op who has thrombocytopenia but increased clotting. They've got some arterial clots or some venous clots. And maybe they received heparin. Yes, good, hit. So sometimes they'll be real obvious and tell you that they gave the patient heparin, and sometimes they'll just say it's a post-op patient. And most post-op patients receive heparin. So either way, anytime you see low platelets plus clotting, think hit. Those are kind of the two factors that should trigger that alarm in your mind. So if it is hit, what do we treat it with? Protamine. Oh, so protamine is the antidote for heparin. But, yeah, so it's, what? Is that Harlingen?
Synthetic heparin.
Synthetic heparin, like leparudin or agatroban, yes. So leparudin or agatroban are going to be our drugs of choice. We obviously want to get heparin out of the picture as soon as possible, but we don't necessarily need to reverse it. Because remember with heparin, the problem is we get an antibody that's formed to heparin bound to PF4. So just reversing the heparin isn't necessarily going to correct the problem. So with bleeding, if we see an isolated decrease in platelets, what are we thinking? Maybe in a young woman, ITP, so idiopathic, ITP. And if we have a patient with normal platelets but increased bleeding time in PTT, this might be another young woman who's got heavy periods, nosebleeds, bruises really easily, but the platelets are normal, but the bleeding time is high. Von Willebrand's. So von Willebrand's. So again, this is a problem with platelet function, not necessarily platelet number. And why do we care about this medicine stuff? Because if our surgery patients have it, it's going to make a difference to how we treat them in the OR. So lastly, if the platelets are low, the coags are high, fibrinogen is low, D-dimer is high, and you see schistocytes on the smear, are we worried? Yes. What are we worried about? DIC, that is badness. So some important causes to remember: gram-negative sepsis because of the LPS can cause DIC, disseminated carcinomatosis can cause it, and then some random OB stuff that we care a little bit less about at this stage. Okay, so for a patient with a burn, remember the rule of nines and how it's a little bit different between adults and kids. And remember the Parkland formula for determining fluid resuscitation of a burn victim. So you'll see some discrepancy in the sources as to whether to use 3 or 4, and for kids whether to use 2 to 4. I've even seen 6 to 8. I think it was in the Pestagna packet. These are the numbers that I found in the most sources. So these are the ones that I memorized for my test. But again, it kind of depends on what source you're using. Things to remember about burn patients: they are more susceptible to infection, but we don't give them IV or PO antibiotics. Why is that? Yeah, it breeds resistance. Very good. So we're going to give topical antibiotics instead. And there are 3 main topical preparations we give to burn patients, and you'll want to know the differentiating factors between them. So one factor, or one topical medicine, doesn't penetrate Eschar, but can cause leukopenia. Which one is that? Oops. Okay. Yes, silver sulfadiazine. Very good. So the side effect of silver sulfadiazine that you need to remember is leukopenia, and it's not the best for third-degree burns because it won't penetrate that Eschar. So what does penetrate the Eschar but is very, very painful? Mafenide. And then the third one also doesn't penetrate the Eschar, and the side effects that you watch out for are hypokalemia and hyponatremia. Silver nitrate. Very good. So I definitely had a question about one of these, determining between the 3 of these agents based on their side effects. So go back and review this before your test if you have time. So some other random burn stuff. Got a chemical burn, particularly in your eyeballs. What do you want to do? Flush it even before you come to the ER. If you've got an electrical burn, the next best step. Very good. Because what's going to kill you? The arrhythmia after the electrical burn. So first best step for an electrical burn is an EKG. If that's abnormal, we got to monitor them on telemetry for 2 days. If we've got a burn patient, especially an electrical burn patient who's got a urine dipstick positive for blood, but there's no RBCs seen on the microscopic exam, what does that tell us? Their pee is red, but there's no red blood cells in it. Rhabdo, very good. So rhabdomyolysis causing myoglobinuria, causing renal failure. So that's another kind of medicine-y thing that they could sneak in there. So if we find myoglobinuria, what do we check? What would kill you? Potassium, absolutely. Because if you've got rhabdo, your cells are bursting and dying. That intracellular potassium gets out and can cause fatal arrhythmias. So we got to check the potassium. So what if a burned extremity becomes really tender, numb, white, cold, and we can't get a Dopplerable pulse? What is that called? Some bad stuff. Compartment syndrome. So the swelling can cause compartment syndrome. The criteria are those 5 Ps. Old school way would be to measure the compartment pressure greater than 30 millimeters of mercury. And how do we treat it? Yeah, fasciotomy. And they even do it at the bedside, I've heard. I didn't do the burn rotation, but I hear you get to do these with some frequency. Did anyone do them? Fasciotomy? Yeah? Was it scary? Surgery scares the poop out of me. It really does. That's why I'm not doing it. Anyway, glad someone will. Okay, so trauma, very, very high yield on this exam. So you can get a lot of test questions, bang for your buck points-wise if you review your trauma stuff. So what do we do with an airway if our patient comes in and is unconscious? Intubate. Good. What if the GCS is under 8? Intubate. What if a dude gets stung by a bee and he's starting to get stridor and he's doing some tripod posturing? Intubate. What if a dude gets stabbed in the neck, but his GCS is 15, he's talking to you like nothing's wrong, but he's got this expanding mass in his lateral neck? Intubate? Yes. What if a guy gets stabbed in the neck and you hear some crackly sounds when you're palpating around his neck? It feels like Rice Krispies under his skin. Be careful while intubating with the fiber optic bronchoscope. Yes. So that crackly Rice Krispies stuff, that subcutaneous emphysema, and you might have a laryngeal injury or an airway injury, so you'll want to take a look at what you're doing with the fiber optic bronchoscope if at all possible. So what about a dude with huge facial trauma, can't really see what's nose and what's face and what's mouth and all that stuff, and the GCS is 7? Crike, good. So when you can't assess where you're putting your tube, your airway, this is a good indication to do a cricothyroidotomy. All right, so you intubated your patient. Next best step. What did you do in the pit? Listen for breath sounds. Good. It's almost too easy, right? You got to take your stethoscope out and listen. If they're decreased on the left after you've placed your airway, pull it back because you have intubated the right main bronchus. So what do? Pull it back. And next step. Well, listen again. Let's say we know we got it now. You do usually get a chest x-ray, but we also want to check the oxygenation status. So, okay. Speaking of chest x-rays, check these out. So, what do you think about this one right here? Is anything there worrisome to you? So this patient might come in hypotensive, their chest really hurts because they were in a really high velocity accident, they're dyspneic, there's some new murmurs. Yeah, so this is traumatic aortic injury. So the treatment here, OR like yesterday. They got to get there soon because we need surgical reconstruction with a clip. So this is traumatic aortic injury. What about this? Pay no attention to this word right here. So what is this chest x-ray? Oh. So that's a pneumo. That's a pneumothorax. And can you see the darker lung fields here? It's a little more hyperlucent because it's air. There's no lung tissue. So this little shrivelly dude here is the collapsed lung, as they've so nicely told us. We've got a pneumothorax. So what might we see on physical exam with our pneumothorax friend? What might we hear? So we hear absent or decreased breath sounds on this side, hyperresonance to percussion. What? If it's a tension pneumo, sure. Yeah, so we definitely want to pay careful attention to the neck veins because if they were distended and the trachea were deviated,